A lot of changes happen during the second half of life. Join Kash Mahmood, owner of Vargo Hospice and Home Health, and his guest as they explore topics to help you navigate the second half of your life. And now, here's Kash.
Hello, everyone, and welcome to Second Half of Life with me, Kash Mahmood. My guests today are the infamous Wendy, Jonathan, and Dr. Chad Niemeyer, as always, the group that talks about seniors and senior care. How are you guys doing?
Excellent.
Doing great.
Fantastic.
We embrace the infamy. So
That's right.
We do. We
said
absolutely
infamy.
do.
I'm so excited to have you guys back. And today we're going to be tackling on the 3Ds: dementia, diabetes, and depression. And the idea is to combine the three into a whole person approach to healthcare. So looking at the connection between the three, especially when it comes to seniors, I'd like to dive in straight into the questions. But before I do, as always, I'd like for you guys to take just a few moments and just introduce yourselves to our potentially new viewers that will be joining us. So why don't we start with you, Wendy?
I'm Wendy Spiller. I am what we call a member growth consultant here at Dedicated Senior Medical Center. We do have our 5 locations here in Houston, and I happen to be at the one that we call North Line.
Jonathan?
Oh, thank you so much, Kash. Well, good morning, everyone. Of course, I'm Jonathan Lowe. I'm the Director of Market Sales for Texas, and I am actually joining you not in Houston this morning. I'm actually joining you in from Dallas.
And Dr. Niemeyer.
hi, everyone. Thank you, Kash, for hosting us. My name is Dr. Chad Niemeyer, and I'm the Center Medical Director at our Northline location, where Wendy also resides. So we're excited to be with you today.
Excellent. Well, let's zero in on what Dedicated does differently to help seniors who are dealing with one or potentially all of the 3Ds. Maybe Wendy, you can start off with the question, because I know you're with us for a short amount of time. You have to go on and help a couple of potential patients that you all have. So maybe you could shed some light on this one, and then we'll let Dr. Niemeyer and Jonathan take it from there.
Absolutely. So I guess with the dementia portion of it, I know it has to do with memory and some of the things that we do when we go out to the centers, or we have here in the center. There's games that we play, puzzles, where there's either 300 to 500 pieces that they're putting together. I know some of the seniors will put them at tables together, because you don't want them to do it by themselves so much, but get a little help. That helps with that depression. They have a little somebody there playing with them and enjoying that time with them. Also, word puzzles. We do have little books that we can get them, and they just like the word circling the words, just finding those words out of all the different letters that are on a sheet of paper, and it helps that mind as well. A lot of them like the Sudoku. Am I saying it right? Sudoku. Some of them like things like that. As far as activities and the diabetes, helping with the weight, we do have what we call dedicated walkers that we have. They have their little purple shirts. They go into the mall earlier in the days, and they will walk around the mall. They have been causing quite a ruckus these last few days, because everyone's stopping them to find out who are they. But it's just a great activity that we have, and they love it, because at the end of it, we do have games. They have to go run around the mall and try to find particular stores, but it's helping them memory as well as helping them with activities and with the cognitive activities, as well as interacting with each other. Some of the people that in their areas that they've never spoken with before, kind of helps a little of that depression. They're able to get out and laugh a little bit. So those are some of the things that we do with our seniors.
And you don't expect to walk into a potential clinic or a center and have these board games and Sudoku and everything else when you're going to go see a doctor. So
Of course,
I think it's that friendly environment as soon as they walk in, that it's an extension of the community. So
Well, Dr. Niemeyer actually has this bingo size going on here at our Northline campus. So that's a pretty exciting. They do expect it when they come here on Mondays. We have someone sitting over here since this morning, waiting till 1:30 to actually play.
Oh, well, I mean, bingo has diehard fans, right? So.
Yes, this is bingo 2.0. You know, we combine exercise with the bingo, so we had to kick it up a notch.
There you go.
Yeah, no. To add to what Wendy's saying, I absolutely agree. You know, we really try to do in our center is engage both. The body and the brain. I think that we do a lot to try to make sure that we're engaging in activities here in the center that our seniors would want to participate in and are welcome and invited to come and participate. We are always looking for ideas, always looking for ways to connect with them. I do believe that in many cases, when you're talking about these 3Ds, diabetes, depression, and dementia, it is very important. Movement is one of those things that I think helps all of these areas. And so bingo size is just one example of things that we do. We're going to be starting Zumba here. We had a group Zumba thing for our staff, and that was a lot of fun to kind of just trial it. And so we'll be doing that with our seniors as well. I believe that the games, as Wendy was mentioning, it's a great way to engage the brain, a great way to connect with other seniors. Right. And I think that that's something that really is good for the heart and soul as well as the brain for our seniors who can come in and connect. So there's a lot that we do that goes beyond just the care that we provide in the patient room. And we believe that leads to a more holistic approach to care that impacts our patients' health. Excellent.
Jonathan, would you like to add?
Kash, I would. And, I think we would all agree that, when we know about the prevalent issue with diabetes, but one of the things I'd like to kind of call out is after COVID and during COVID, we saw a lot of seniors being isolated. So there was a huge increase in depression. There was an increase in depression in everyday people who were actually under 65, to say nothing about seniors whose loved ones, number one, might be out of state, or who, again, because of COVID and restrictions, depending on where they were living, couldn't really have any visitors. So one of the things that we implemented, aside from doing our in-center activities, and of course, we're getting everybody back into the centers, but we also implemented what we called love calls, where we were outreaching to our seniors. And that was initially designed to see how the senior was doing, to talk to them, to see if they had any medical questions, and to see what their overall health was. But we discovered a side effect. And the side effect of that was that a lot of the seniors were just lonely, that they wanted somebody to talk to, and we were able to engage them. And I am proud to say that we continue that practice. We continue those love calls. And for our sickest patient population, we also do what we lovingly call tuck-in calls, where we're starting calling them on Thursdays, seeing how they're doing, making sure that that they have their medications, making sure that they answer appropriately. So I have to tell you, I kind of love the overall approach, because we're bringing them in the center, we're engaging them, we're talking to them, but we're also doing phone outreach as well, just to see how our patients are doing. Because Dr. Niemeyer will tell you that from time to time, just listening on a phone conversation, how somebody's answering can sometimes tell a lot about their medical condition. Maybe there's an issue that we know we need to get them in, or we need to check on.
Excellent. That's great. No, you guys really do a lot and go above and beyond for the community. Wendy, I know you have to drop off. I really wish you could be here for the whole thing, but hey, you've got some people that need help. So please, you're more than welcome to drop off.
Thank you. Appreciate it. Have a great one, guys.
Caring for seniors is very different than caring for a younger dynamic or a younger demographic. What are the 3Ds that the doctors should be paying attention to? And what are the trigger points where action becomes more critical?
Yeah, great question, Kash. So when we're talking about the 3Ds, we're talking about dementia, depression, and diabetes. And all of these are very important in our senior population. So focusing on one at a time, if we're looking at dementia, so we know that changes occur over time that can predispose one to the signs and symptoms of dementia. So memory loss is, of course, one of those things that we see commonly. There's memory loss that occurs that's simply age related and not tied to any kind of medical condition. But then there's types of dementia such as Alzheimer's, which is the most common type of dementia and one that most people are probably most familiar with. There are various other sorts of dementia. There's vascular dementia, those who may have had prior strokes, or perhaps they've had some vascular disease that has caused some dementia. But essentially, it presents in a way in which someone's memory can decline. That can affect their activities of the daily living, their ability to take their medication, their ability to make it to appointments, their ability to do the basic activities of daily living in their home, such as prepare meals and things of that nature. So certainly, we in our setting at Dedicated Senior Medical Center and in senior care in general, this is something we screen for, something that we're looking for. When it comes to depression, again, this is something that goes hand in hand with dementia, because in seniors, many times depression can manifest as memory loss, lack of attention or focus and concentration. These things that sometimes can come off appearing as though it's dementia, but in many cases we find that if we probe a little bit deeper, there may be some underlying depression, and many patients do respond very well to therapy, and you'll actually see that their cognitive functions improve when they are initiated on therapy. So we screen for that as well. According to the CDC, amongst community dwelling seniors, 1% to 5% may have depression, but it increases significantly when you're talking about those who may have medical conditions, those who need some sort of home health care. It's about 13.5%, and those that are hospitalized, about 11.5%. And those who have diabetes, which we're about to talk about as well, it's double the risk, 2 to 3 times actually of the general population. Depression is much more common in that patient population, and so these are all things that we screen for. We always are looking out for because they're treatable, and they're things that we can help our seniors with. So finally, the diabetes arm of it, certainly in our patient population, we're screening for this regularly from the very moment that they enter our clinic. That our screening tests do test for diabetes. If they don't know if they've had a history of diabetes, we do test for that, and ultimately we can help guide them through both medical and also lifestyle changes that can help to improve their state of health.
So Dr. Niemeyer, based on what you described, there is certainly a strong connection between depression and dementia. And you guys screen and test for that when somebody's in there on a regular basis. For a family member that may have a senior that is starting to show either dementia or depression signs, I'm not sure one leads to the other, but I think having the two together makes it even more critical to get the right kind of care. So is there any kind of sign that they potentially should be looking for to understand the urgency of the situation?
It's a great question. Absolutely, there are many signs and symptoms, whether it be dementia and depression. And so, and in this particular case, I would say this, just to clarify, depression can lead to symptoms that mimic dementia. So it can certainly look like dementia, but really the root of it is depression. And certainly dementia can coexist with depression, and many seniors will suffer both depression and dementia. So the depression aspect of it can make the manifestations of dementia appear worse. And so when you treat that, certainly some aspect of that dementia can improve. And so things to look out for, certainly we know that our seniors with their loved ones, and we look out for those changes in the memory, especially the short-term memory loss, having a conversation, just explaining something and then it just not registering or just not being able to keep track of that. We just had a conversation that we were going to meet for lunch, and unfortunately, mom or dad or grandma, grandpa, it just completely left them. They just didn't remember it at all that we'd had that conversation, and kind of circling back to the same thing. So conversations like that, certainly inability to remember if medications were taken, or or what medications they do take or should take. Keeping track of other basic activities. If they have animals or pets in the home, have they fed them? Are they feeding them more than they should because they can't remember if they fed them or not? Sometimes it can appear, both dementia and depression can appear if they're seeming more disorganized. Certainly clothing that mismatches or is not fitting, or clothing that is not certainly not in fitting with what you normally would see with them, that's out of characteristic for them. And then depression, certainly just we look for low energy, low appetite, usually sleep disturbance, things of that nature. But the way in which it can look a lot like dementia is when you start to have that inattention or impaired concentration and focus that occurs with depression. And sometimes that can lead to symptoms that look like memory loss, but really it was just that the information never was received. And so that can mimic dementia as well, but they go hand in hand.
Okay.
Go ahead.
There's
something else, Kash, that I'd like to add. Dr. Niemeyer is absolutely correct. And, one thing that really I think we see, and Chad, I know you've probably seen this as well. Unfortunately, a lot of family members sometimes see the signs and symptoms, but are kind of in denial. They don't want to admit that their loved one is having memory problems. Oh, dad's just a little forgetful, or mom just forgot. She's just things are hectic. So by having the right primary care, and by having a primary care provider that actually has the time to spend with the patient, to actually ask the appropriate questions, to help them go through the process, to determine, are we dealing with depression here through screening, or are we dealing, with dementia, or are we dealing with a combination of both? Because I know from my own personal experience, my own family members with my mom's dementia, everybody wanted to be in denial except for me. And I was like, no, we need to have her evaluated. We need to make sure that, she's not answering appropriately. And everybody's like, no, again, just too much, activity on mom. She's confused. Well, exactly. And the thing is that, the other thing too, and Dr. Niemeyer would tell you, is that the other underlying cause, what if they're diabetic? What if they're having fluctuations in their blood sugar? What if that's causing the confusion? So by having excellent care by an individual doctor, like Dr. Niemeyer, he's going to be able to screen the patient. Are we looking at a medical cause? Are we looking at depression? Are we looking at dementia? Is it a combination? Because let me tell you something, if you're going to go in and see your provider and you've got 3 to 5 minutes, I don't know anybody who can make that assessment in 3 to 5 minutes. That's why you've got to have the right primary care. You've got to spend the appropriate time. Your primary care doctor needs that 20 or more minutes with you. They need to ask it. We need to do those screenings in advance. We really need to take the overall look at the patient, because if you're not doing those things, something's going to get missed.
Right. Yeah, no, I totally agree. And I'm glad you touched on diabetes. Dr. Niemeyer dove in deeper into dementia and depression, that combination. And Jonathan, thanks for bringing in diabetes into the equation as well. Diabetes by itself is a very devastating disease. Dr. Niemeyer, maybe you can build on what Jonathan said. Why is it important to also look at the underlying depression when treating diabetes in seniors? What are the potential ramifications or consequences if it went unaddressed?
Yeah, that's a great question. And yes, I agree. Thank you, Jonathan, for those comments and for that great segue. As I mentioned, depression is certainly common in diabetes. It's actually 2 to 3 times more common amongst those who are diabetic than those who are not. And so it is really important to screen for it for a variety of reasons. Number one, because diabetes can be a difficult condition to manage for patients depending on the severity. It requires an adherence to a lifestyle, certain dietary restrictions, things that you would want to follow, activities such as exercise. There's certainly medication compliance that we have to factor in as well, and all of these require someone to really be able to receive and understand information, to focus on the task at hand, and to certainly be motivated to take care of those things so that they can achieve a healthier body and a healthier state from their diabetes standpoint. All of those things are impacted by depression. So if someone is depressed, then a lot of times, as I mentioned, concentration and focus and attention, those are kind of things that we do see are affected by depression. And those are things that are necessary in order to take care of the day-to-day when it comes to managing your diabetes. So certainly you can see how diabetes may not be as well controlled if the depression is not also addressed. And so it's very important that we screen for that, and that when necessary, that we treat for that. And diabetes in and of itself certainly is a condition in which, being a chronic disease that is very in the right care, certainly it's something that can very well be managed. But if it can take a toll on an individual, and certainly it can be overwhelming at times. And for that reason, I do see several patients who do actually experience those symptoms of depression, of dealing with a chronic condition. And so it's really important that we do look for both diabetes and depression, but certainly when we know someone is diabetic, know that is more, that's a higher risk of depression, and we need to be looking for that.
Excellent. You guys are doing a great job with that are coming into the clinics. You're doing all sorts of tests, you're diagnosing them, you're checking the connections. But we, and the kind of diseases we're talking about, dementia, diabetes, depression, these are chronic conditions. And depending on where you are, underserved communities, for example, it gets even harder to manage the dementia element, the diabetes element. So how do you partner with other companies or organizations to ensure that seniors continue to get the continuum of care in their homes as well?
I'm sorry, go ahead.
Then please go ahead. You lead the way on that one, and I'll follow up.
Absolutely. And Kash, that's a great question, because one thing that we have, again, we have an in-house social worker. So say Dr. Niemeyer identifies different social determinants. We've mentioned on previous podcasts that really healthcare is only one barrier that our seniors had. They can have food disparities. They can be in unsafe environments. They could have housing issues. By the way, all of that's going to feed into these conditions. So what's going to happen is we have to have external partners. We're working with food banks to help with the food disparity, for example. Somebody may need hospice. That's going to be something, again, we're going to work with somebody outside, because that's going to be special types of needs. We may have individuals, again, that are in unsafe environments. And let me tell you something, depression can be exacerbated by your living conditions. It can be exacerbated by not having food, from dealing with pest infestations. You would not, or maybe, most people would not realize what most of our seniors in underserved communities are really facing. So it is crucial that we have these external partners, that we identify. So if they have that food disparity, we're getting them with a food box program. If they're in an unsafe environment, we're working to get them and find them better housing. If they have a pest infestation, again, we're working with sometimes their plans, the carriers that they have specific plans that have social determinants on there that give money for certain things. Utility payments, for example, say they're not able to make their utilities. So we're trying to help them get payments for their utilities. So again, that they can make sure that they stay cool during the summer and warm during the winter. So for us, I have to tell you, healthcare is just the beginning, but we identify so many other problems. And again, it really starts with our providers. as they're talking and going through the social medical part of it, they're uncovering a lot of that. And I'm going to defer to Chad because he's probably going to have some more information to write on that.
So, those are really great comments, Jonathan, and I appreciate that. I think that, the focus on social determinants and what supports a patient has, or maybe some barriers that they may have to receiving optimal care, these are things that are very much a part of our model. It's something that we do every single day. We screen for those kind of factors that might potentially limit their ability to get care in the home. And so, and we work to help address those barriers. So absolutely, we're spending time talking about that. So I think that that's something that sets us apart from a lot of places is we're not just strictly focusing on the medical and saying, hey, your diabetes is not well controlled. You need to take this medicine, make sure you eat this diet. No, we're saying, well, who do you want us to talk to that can support you in this? And what kind of support system do you have at home? Tell me about your home. Tell me about, do you have access to food? Is that something that have there been days you've gone hungry? Those kind of things. What kind of transportation barriers do you have? Those are the kind of things that we work to address. And if we feel that the patient does not have the support that they need to be able to achieve their optimal health, then we're going to work with our partners in the home health and sometimes hospice realm, and we're going to work to make sure that we provide that support for our patients who need that additional support. We do not want them to go without the care in the home, and so if it's someone who is the goal is to be at home and to continue that care at home, we're going to work with partners in home health and hospice to try and work to get that support there for them. And then we work in collaboration with them. We communicate to make sure that they're getting their needs met.
Excellent. Well, gentlemen, as always, this has been extremely informative. I love having these with you guys on the show. We get to share a lot of information about the challenges themselves that are in the community and how you guys are going above and beyond to solve them. So once again, thank you for being on the show. It was fun to have you again.
Thank you so much, Kash.
Thank you, Kash. Really appreciate it.
Absolutely.